Krishnasai, a consultant medical geneticist and genetic counselor, currently working at Progenics Laboratories, Hyderabad. With over 5 years of experience, I have had the privilege of working across oncology, pediatrics, neurology, and clinical laboratory settings. I hold a board certification in genetic counseling, and I'm proud to be a gold medalist in medical genetics from Parul University, Gujarat. I'm truly honored to moderate today's session alongside the esteemed Dr. Deepa Bhat as we explore the pressing issue, hemoglobin crisis, India's battle against sickle cell disease. It is our immense pleasure to welcome a distinguished expert in the field of medical genetics and rare disorders, Dr. Deepa Bhat. Dr. Deepa Bhat is a professor at JSS Medical College and Hospital, Mysore, and a level 2 BGCI certified genetic counselor, whose career blends academic excellence with compassionate clinical practice. With over 50 publications to her credit and research grants exceeding 3 crores from prestigious bodies like ICMR, DBT. Dr. Bhatt has been at the forefront of transformative research in rare genetic diseases and hemoglobinopathies, including her pivotal role in the ICMR National Task Force on Sickle Cell Disease and a Wellcome Trust-funded population-based registry in Charamrajanagar. She is also the Joint Secretary of the Mysore Hemophilia Society and the Coordinator for Organization for Rare Diseases India, ORDI, Mysore Division, and the Karnataka Blood Cell nominated sickle cell expert. With a powerful blend of clinical insights, academic rigor, and a passion for public health, Dr. Deepa Bhat continues to inspire the medical genetics community across India. Please join me in welcoming Dr. Deepa Bhat to today's sessions. Ma'am, we are very fortunate. Yeah, very eager to listen from you. Over to you.
Good afternoon, one and all. Thank you, Dr. Krishnasai, for that one introduction, and I am humbled. And also, I would like to, I'm always indebted to ORDI because whatever my genetic counseling journey till today was the soul as well as a backbone who supported me from day one was Organization for Rare Disease India. So because of this, I intended to, being a sickle cell researcher, I thought I should utilize this platform for two things. That is, number one is sickle cell. We all know that it is a genetic disorder. It is the first genetic disorder which has been taken in a mission mode. That is, national program has been initiated. So, and also it goes at a community level. So how many of us might be day in and day out during the routine clinical practice would have come across this patient, but are we really thinking about them? Because the manifestations, it's an invisible disease. We may be living, who knows that some of us ourselves may be carriers too. So I intended to spread the awareness regarding the biggest launch which has happened in Indian history, that is for a genetic disease as a mission mode, and also give a thought process in future that how can we bring all the genetic diseases into such a national program. So if such thought process is provoked among the medical fraternity, this would really make a huge difference in lives of many of the families, caregivers, and also would be preventive. Second thing is, I was really heartened to see that I have been through the development of this mission guidelines and also how it is being executed. Till today, there is nowhere a defined role of a genetic counselor in management while designing the program as well as during the execution. There is no role for a genetic counselor. So, and it's like it's a disease of everyone, so everybody is needed, but the role of each of the person, though it is very well defined on paper but not at into practice, so we need to really work in this regard. So with this, I would like to, considering a community from basics till the most experienced in sickle cell disease, I would like to cover from the scratch till the advances. So why was this disease taken as a national program? It was thought as a global public health burden. So WHO has certain criterias uh, based on which it chooses a disease as a public health concern. So sickle cell disease fit into this, and hence it was considered as a national program. So initially what happened was, or even till now, Anemia Mukt Bharat has been ongoing program across India. In that Anemia Mukt Bharat, the sixth pillar is considered as anemia causes other than the iron deficiency. So all the hemoglobinopathies are just fit into this. So how far the people are getting screened, how far they are benefited in terms of the national welfare schemes, has it almost, it's like a neglected disease. So though I don't call this sickle or thalassemia as a rare disease, I would rather say this as a most neglected one, because that sixth pillar has been really been almost not taken into consideration wherever the anemia mukt bharat is happening. And the next thing is that in that a portion of it has been pinched out and made as a totally a new national program, that is a national sickle cell anemia elimination mission. So now how far the hemoglobinopathy is getting justice, still we need to explore in detail, because we are in just an initial stage of the mission. So India is third highest. So next to Nigeria and the Democratic Republic of Congo. So we stand third in the global burden of the disease. And what is so surprising in India, we can't compare with African American or a Nigerian population, because the severity across India, you can see in the right side picture here, where the color, which number of birth and also the severity, it is totally different. When we work with different states, we find that the pattern of disease is extremely different. If when we go, for example, if we go to central India, it is different. As we go away from the equator, it also varies. And because it was considered more prevalent in tribal community, so that is considered, they have started or initiated screening in the tribal population. But another biggest myth, I would say, is that the tribal population has been overrepresented. We get in practice lot of non-tribal population also who are affected with sickle cell anemia, but definitely the program would cover, but this, will it really delay the diagnosis? So that's the biggest concern as a national program, because first 3 years it's only ST population is the concern of the government. So that's where I would like to, is this hemoglobin is in really crisis in terms of a national program? That's a one concern as a sickle cell uh, person I would like to bring to everybody's notice. So we can see that here it's wide geographical distribution. We divide it into the different region where severe, the prevalence is high, moderate. So some of the equatorial like Gujarat, Madhya Pradesh, Chhattisgarh, upper part of the Maharashtra, all these fall under high prevalence areas. And coming to Karnataka, and they all fall under a moderate, Assam, they all are under the moderate prevalence states. So with this, in 2023, in July, in Shadol district of Madhya Pradesh, under the presence, in the presence of Honorable Prime Minister, so this elimination mission was launched. The thing is, when they initially named it, it was called as eradication mission. So eradication, I don't think we can eradicate a genetic disease so far. That is 2047 is represented because it's 100 years of independence. So later everybody realized that we cannot eradicate, but the gene, because even the carrier gene pool will take years together if we stringently do the screening, but that would be practically almost not possible. So they made it as elimination, That too, elimination of not the gene, elimination of the disease as a public health burden. So this was the concern with which this was launched. Almost we have completed now more than 1 year, 1.5 years. This July we will be completing 2 years of this program. So this was not started across India. It's in 17 states of India, including Dayo Daman. Sorry, it is in the Andaman Nicobar. And coming to Karnataka, because I'm from working in Karnataka, it is only in 7 districts, which was taken as a tribal prevalent districts. And that the target which was given is 70 million people has to be covered by screening from 0 to 40 years in first 3 years. So this was the very, very enthusiastic and I would say over enthusiastic target with which they started, but lot of initial glitches which I observe being within the system of this mission. So I'll take you through one by one all those issues. So the vision mainly of this program was to improve the care for all the sickle cell patients and also to reduce the prevalence, and also it had awareness. You can very see this is an open source document. If you Google the National Sickle Elimination Mission, the website will give you everything. Lot of study materials are there, lot of awareness contents are there, and also everyday dashboard across India is available in this platform. And if you open those books, very beautifully defined, where it's on paper, the increasing awareness in the community. You can see that the first and foremost importance is given as a awareness. But the issue what is happening in today's screening is, in order to reach the target given by the government, without awareness, the mass screening has been initiated ongoing, and in some places because of the pressure of the bureaucrats, the screening has completed at many places without even knowing what is happening. So then strong network for diagnosis. You can see that there is a network are happening at the field level, at the primary healthcare level, at the level of the sub centers. So all these are happening. There is no awareness if you see above, and below if you see there is no proper post diagnosis. What next? Doctors at PHC, medical officers are not aware what next. We are diagnosed. So these are so many the challenges which are at the field now. And also there is no robust monitoring system. It's like I haven't learned the swimming, but I have jumped into water now, and I'm slowly trying to figure out how will I learn swimming. This is exactly what we are seeing. No awareness, no network, proper linkages, no robust monitoring system. Without strengthening the primary healthcare system, without referral, only the mass screening has been initiated. You can imagine the lakhs, the number which I gave you, the crore number. This would be screened without knowing why they are getting screened in this national program. This would be really a concern which we as a genetic specialist or even the practitioners who will be dealing with this patient has to be really worried about or concerned about. So you can see the target, the 17 the states where this is the dashboard from the Ministry of Health and Family Welfare, the numbers which are screened, the target given, and there is something called, as you can see, the last one, the card distributed. So the card also, I'll bring it up later. This is still a matter of concern with respect to sickle cell cards. So this is a dashboard in the website, which you can see. It's an open source. So you can see that 44 crore 92 lakhs is screened. In that, it says 1,82,000. Can you imagine in India? I think this was into 2024 itself. We have lakh, 82,000 affected, 12 lakh carriers. If we take, we still don't have a proper prevalence because we don't know the exact coverage. Why? Because the numbers of screening was done as per the 2011 census, but we are already in 2025. The number of people screened was based on the target given from the numbers of 2011. So we might have missed screening. Why? Because when we go to the field or when we in the hospital, I get patients from the area where screening is completed. He has a classical symptoms of sickle cell disease. When we say that, are you being screened? He says no. So many would have been missed also. So this is the status of the sickle cell screening under the mission. So in Karnataka, you can see the 7 district. Every day the government system is very strict. Every week meetings happen. Every PHC or every district sickle cell officer has to report, and they have made a mobile app where it has got 2 portions. So it is earlier it was Aadhaar linked, ABBA ID linked, but there was a lot of difficulty. So they have now removed that linking with Aadhaar, but it's being entered in the portal at the peripheral level. And now recently the second edition on the clinical and laboratory reports has been added nationwide. The access will be given to the community health officers in the taluk as well as primary healthcare level. The control will be by the district sickle cell officer, in turn by the state sickle officer, and it will be under the NIC, National Informatics Center, will be monitoring all these data across India, that is in these 17 states. So number of screening done, number of confirmatory tests done, what was the mode of testing, what's the age, what is the category. As currently there are only 3 category entry, that is SC, ST and others. Only this can be entered. Are they taking hydroxyurea? Is the card distributed? They have given a sickle cell card, which the intent of this was very good. The card will say, without even the color match was there, it will say whether you are a sickle. Yellow color total is you are affected, yellow color half is you are a carrier, white color is a normal. But the problem with the card which has been observed recently is that the people have started stigmatizing, because if you are having a card, you are affected, you are not eligible for the marriage. So these are so many issues which were really not thought of. They treated sickle cell disease like any other disease, tuberculosis, malaria, or even any infectious disease. So this is one big concern, where a genetic disorder, when it was taken into a mission mode, should have thought from a different angle. So to coming to the community, to just brush up on what is sickle cell disease. So it's the disease of red blood cells. So you can see in this, the cells become sickle shaped. So here in the chromosome 11, there are hemoglobin HBB gene is there. So, and here in this particular disease is called by different dialects. Different names are there. If you see, I've written 4 names: Kudugolu, Kudlu, Arivolu, Sickle Kaile. So these are the one which are in and around some 300 radius of Karnataka. In my own setting only, it is called by different name. So they are called by different name by different people. So it may not be thought as a sickle by the local people. So we all know that it's an autosomal recessive disorder where 2 parents will be carriers. So 25% of the progeny can be normal, and 50% of the carriers, another 25% is the affected. So what is that? Such a simple, we deal during the genetic counseling, lot of reports which are very challenging to interpret, unknown variant of unknown significance, and starting from the missense mutation to frame shift, deletion duplications, triplet repeat expansions. But here it's just one simple single base substitution, that is in the beta globin gene in the 6th position of the beta chain, you can see. So causing there, instead of glutamic acid, what is happening? There's one small change. One small change. Can you see that it has made an India or a globally to go for a national program, that it has become a valin. So instead of GAG, there is a GTG. So this results in formation of a hemoglobin, which is SS. So if you have two homozygous copies, we call it as SS instead of normal, that is AA. So what happens is, if there is such a hemoglobin, there is a increased polymerization of the hemoglobin molecule. So you can see that because of this, there is a decreased deformability of the red blood cell, so makes it more fragile, and when it passes through the microcirculation, there is a chance that the cell membrane is prone for its shape is already different, so it will be damaged, leading to hemolysis. And with reduction in the oxygen, it assumes a sickle cell, so it blocks. So once, there are two major issues here. One is there is a blockage, one is there is a early breakdown. The normal RBC, which is supposed to stay for 120 days, will have a shorter lifespan. So excessive hemolysis. So all the symptoms which we see are because of either hemolysis or because of the vaso-occlusion. So in the blood, we have normal. All of us adults have got 2 alpha and 2 beta chain. So 95% up to our normal adult hemoglobin, and very small amount we have delta 2, that is HbA2, and some 0.6, very minute amount is another one, that is a HbF. So this is all of us adults have this. The newborn initially will have everything will be HbF. Slowly by 5 to 6 months, the HbF goes on reducing, and an adult hemoglobin starts taking over. And by 1 year, it will be an adult hemoglobin. So this is normally seen. But in sickle cell, if it is purely both are SS, we call it as homozygous. But this is not so simple as we think, depending on the region. So for example, sickle as well as a beta thal carrier, a person can be a thalassemia carrier. Individually, if I am a sickle carrier, or individually, if I am a beta thal carrier, I may not have the symptoms which are so much concerning. But if they together are present, suppose I get sickle from one parent and the thal from another parent, then it is further damaging. That is, we call it as sickle beta. So this is very, very commonly seen, and this gets missed in the national program. Why? I'll tell you during the diagnostic testing. Other than all other variants, there are many chances that could be missed during the national program. Number one is, as I mentioned, sickle beta. Second one is, if we go towards the Punjab or a Rajasthan side, there is the D variant. And if we see is less seen in India, there are, but more in African population. And if we go to Northeast, it is more of a sickle E variant. Assam, if anybody in your, maybe even in southern, in Mysore, if somebody comes from, they would have migrated for a work reason. If an Assamese person comes with this anemia, we try to evaluate for a SE. Further, in the sickle gene, we have haplotypes. So very common what we see is Arabia Indian. There are many more: Cameroon, Senegal, Benin, and Bantu. So these could be the reason for the variation in the phenotype among different geographical locations. So you can see, just to summarize, maybe most of you are aware because it's a very simple disease. The commonest symptom across India we see is pain anywhere. Last week I had a 15-year-old child who was first time diagnosed as a sickle cell disease. But when I asked the symptom with the mother says since he was 5-year-old, he was having lot of pain at different parts of the body, not severe enough to hospitalized. At 15th year, he has undergone hospitalization. But when I saw the child was looking like he was looking Cushingoid. So when on digging history in very great detail, we found that the parents were taking him to a quack, the nearest easily available the practitioner, who was giving him every time along with a painkiller a small dose of steroid. So from past 10 years he has been taking steroid, leading to a adverse effect, that is the Cushingoid feature, which was ignored by even, because the lack of awareness made even the doctor to, or a practitioner, I would say, to miss the diagnosis of the sickle cell. So some of the region, even many times children less than 5 come with, they're excessively crying. And if you see that the small joints in the fingers are swollen, the dactylitis, so pain abdomen, lower back, very simple. Many times it would be just anemia or growth retardation. The child is not growing properly. Then recurrent infections. So how do they present? Simple fever. You can see pain, fever, swelling, anemia, just a general symptom. Even we will have one or two in a combination at any point in life. So this is the one which makes most of the people to miss the thought that until unless you have sickle as one of the need for evaluation in mind, the chances of the detecting or advising them to go for a testing would be missed. Other than that, because of severe hemolysis, there is even the repeated jaundice is also. And we had some instances like a child came with gallstone, 8-year-old girl came with a gallstones. So retrospectively, when we did when the sickle testing was found to be positive. Few of the kids we have came to the hospital having bone infection, osteomyelitis. So they were detected to be sickle cell positive, and excessive the repeated infections were found to be sickle positive. So wide variety of symptoms could be one of the presentation of a sickle cell disease. So usually what we have observed, what triggers them, the symptoms, we call it as the crisis, is the infections. So excessive consumption of alcohol or even smoking, and most of them in the village setup, they are manual laborers, excessive exertion, they come and get admitted. Extreme weathers, either very severe cold or the humid. Nowadays even the excessive rain is also, we have seen, is more triggering than the cold. And pregnancy itself is a high risk factor, and dehydration of any other cause can trigger the symptoms among the sickle cell patients. So the complication. So if they're living with sickle cell disease, it's fine. But sometimes, some percentage of the people, it varies. So if in Karnataka, we hardly have 10 to 15% of the patients who go for crisis. But when I talk with experts from Maharashtra or even Madhya Pradesh and Orissa especially, the number of people going for crisis, we call this as a crisis. So pain crisis, vaso-occlusive crisis, VOC, we call it as vaso-occlusive crisis, are the percentage is very high. And we even had one child who came with stroke in young, who was found to be sickle positive. Suddenly, if it goes and blocks the vessels in the chest, they can come with severe sharp chest pain, which could be missed many times. As I mentioned, bone necrosis, repeated damage to the filtering mechanism of the kidney can lead to renal failure. The spleen is always the bears the brunt because it filters the blood. Many of them, when they reach the diagnosis, would have had autosplenectomy. They would have had a shrunken spleen or not visible also. The stones in the gallbladder and painful erection. But usually in Indian context, we have not seen much compared to the African or American population, priapism and pulmonary hypertension. So you can see repeated, the non-healing leg ulcers are also seen, and damage to the kidney leading to microalbuminuria, and damage to the retina also, so leading to vision issues. There is no organ in the body that is left. So anywhere where there is a blood circulation, anywhere there is a occlusion can have a, it's like a slow poisoning. By the time you have any visible manifestation, damage would have already been done. So in practice, how we observe in the field is that their HP, the anemia, what is seen in thalassemia or other types, so is not much seen. We will have 8 to 9, many times the between 7 or 8 to 10 is a hemoglobin is observed, but the symptoms are more severe. In vaso-occlusive, the HP levels are good, but episodes of prime crisis, either chest syndrome or avascular necrosis is seen. Another category is hemolytic variety, where they have moderate to severe anemia with high retic count and LDH levels are elevated. So there are people who have only pain episodes, but the observation in India is when you, if you see publications, African or Americans have low HbF levels. But in India, the HbF level as a protective measure is higher. We see almost 10 to 15%, even more of HbF, which might be the reason for the lower in the or a better life or reduction in the severity of the disease among the Indian sickle cell community, affected population. So what has been done in the national program now is anybody, tribal region, 17 states and selected district, 0 to 40 years, they undergo screening irrespective of their symptoms. So, but what is missing is that extended family screening has to be done. If 1% is found to be positive, pedigree has to be charted out and all the connected members have to be screened. And the last is the symptomatic. Anybody who are presenting with these from the endemic area has to undergo the screening. So if these three are combined together, there would be a better coverage of the screening. Thus, you will identify more people. So this was the age-old test. Even in 1960s, this was only available. You can see it's a screening test. It's called as sickling or a solubility test. Only thing is sodium metabisulfite is added to saline and this will causes the deoxygenation, triggering the RBCs to go for a sickling state. So if you take a drop of the blood, put it into the buffer, which you can freshly prepare and utilize wherever you want, even in your home setup also, or any least resources you can do, and drop of blood is put and then you read. If you can see the line here, it is sickling negative. If the turbidity doesn't allow, you can see the second, third and fourth. You can't see the line, it is sickling positive. But only problem here is that it cannot say whether he is carrier or he is affected. It will only say sickling positive or sickling negative. So this is the only thing. Even prior to that, one more I would like to add is, suppose you are doing in your routine clinical practice, generally most as a baseline, CBC and peripheral smear are routinely done in different setup. In the peripheral smear, accidentally many times you find that the peripheral smear shows sickle cells. Then there will be anisocytosis, polychromasia, or even oval jolly bodies. There are certain indicators which indicates that there is a hemolysis which is happening, increased retic count. All these, if you happen to glance through during the routine genetic evaluation or a counseling time, then you can even think of people getting a confirmation test done for the hemoglobinopathies. So this was done earlier. Even now, some of the states use solubility first because it hardly not even cost 10 rupees or more. So here this test is done and then they are going to go for a confirmatory. But this alone is not considered as a final diagnosis. So next there came a HB electrophoresis. So a lot of the electrophoresis method like gel sheet was used. You can see a control is here. Then there are comparison lines. The one which is heavier, it is behind. That is the HBS, moves little slower. It is behind. The F next and A is in front. And with the comparison, you can see that there is a control and this is only A. There is A and S. This happened to be a carrier. and there is S and F. You can see that here is the affected. So this was used, but still we had even tried this even before the mission at the level of the primary healthcare, but running cost and the challenge of training the less skilled laboratory technician for this procedure was a challenge. So next came, this is the still considered as a gold standard confirmatory test in routine district health system. So that is HPLC, that is high performance liquid chromatography. So that will elute, we can see different A0, that is adult, A2 is also seen, and you can see A2 is 2.5, that's normal. S window is less than 50 is considered as carrier, more than 50 is considered as a affected. Advantage of HPLC is, other than the sickle, if sickle thal, sickle D, all these are eluted in the biorad variant, what you are seeing. Now, even capillary electrophoresis is also beneficial because some of them, like E variant, is separately eluted and that can be detected properly. But in the district medical colleges, they have been supplied with HPLC instrument, and this report is essential in the mission for that is a basic requirement as a confirmatory test to enter into the national portal and get all the benefits of the program. So beyond this, anything like confirmatory genetic testing, they are all accepted. This is basic minimum, that is HPLC. So now what has revolutionized the national program is what is called as point of care testing. So this is a very simple disease for a national level. You go to a field, at one go you screen hundreds of people. This is point of care testing. It is based on a lateral flow immunoassay. So you can, if you want to, you can collect the details later. So this is just one, you put a drop of 20 microliter would be enough. You put into the buffer and dip it and you read the line. But one confusing thing was, this was hemotype PSC, which was initially came, that gave a ulta result, and later came was the this variety where it's within 3 to 5 minutes you can say if the kit is very good. You can see one drop of blood, similar to the what you do for a diabetes, that is your random blood sugar testing. You put it into the buffer, shake a bit, and then put it into the well, like urine pregnancy test is done. The buffer flows and control line is there, and if A and S is there, then it is a carrier. And if it is only S, such a clear line, you can see this clearly says this person is affected. Most of the time, if the kit is good, we had found that almost, and they say it is almost 96% to 99% sensitive. So this was considered very useful method for screening at the peripheral level, and easy. You need not even have a much expertise in doing. Anybody who knows how to prick and maintain a aseptic precaution at a field level can perform this test. So later now, in some of the states, they are using an instrument called Gazelle. The advantage of this is we can get to know both sickle and thalassemia as of now. So this is being used. Some states use directly Gazelle. Some states use, like Karnataka uses POC followed by HPLC. Some of the states are using solubility followed by HPLC. So the authority has been given to state health authorities to to decide whichever mode they want to choose based on their respective health the guidelines or whatever prescribed regulations. So this is one method. Some of the Tamil Nadu is following solubility followed by Gazelle. So these are the things which is followed. Even some parts of Orissa is also using the Gazelle. So as I mentioned, to revise, there are point of care testing. Why I brought this issue was, I keep getting a call from different companies. We are planning to devise a new method of sickle cell testing by this method, that method. Like, shall we market it? but already the government under ICMR approval, there are certain regulation. If you ICMR has to approve your method, then only that will come into the respective state government portal. That has been made mandatory, because in the sickle cell portal drop down menu itself gives by which method did you get tested. If that method is not enlisted in the national portal, then your test will not be considered as a diagnostic test for the patient. So if any of the companies are coming up with new diagnostic test, then you have to really think, because the market is already functioning. So putting all the efforts henceforth, because even yesterday I got a call, we have come out with a new method. So definitely, how far are you going to approach ICMR with the required number of samples, get their approvals, then get enlisted in the national portal is the biggest challenge. Those who have done would really understand how much process is involved to work with government and get all these paperworks and approval done. So next, the biggest boon now is the dried blood spot testing. So it has been regularly done now. Why this has an advantage is, if I have a newborn, so newborns it tested by these method, because of the HbF level, I may get an inconclusive report, including the HPLC. So DBS is one method, has certain advantages. Number one is I put it in the DBS, and whatever method I want to do in future, I can dry it, transport it into one particular central lab, and utilize it for several methods. If I use it with the whole blood PCR or even a DNA extraction and diagnosis, you will be able, that would be the best method for newborn screening without interfering the interference due to presence of the HbF levels. So we have finally Sanger, it's a point mutation, so easily done genetic testing. So that's required. We can directly offer the prenatal diagnosis until if we are very sure it is not the variant. So you can see the heel prick, or even usually that is ideal. The DBS spots are dried properly and it is transported to the laboratory. Then a punch is taken. Advantage is that remaining spots can be used in future for many more studies or any of the other requirements in future also. So this is one of the good method which solves the newborn screening difficulties or challenges which we face. So now these were the diagnostic test. Genetic, definitely I have not added in detail because it's just a point mutation. So what do we, once diagnosed, what we usually advise is drink a lot of water, because this is wherever we have, many places we have distributed water bottles to people to just to commemorate, to say that drink this much bottle per day as an education event. Every lifetime to support excessive RBC production, we support them with folic acid, multivitamin, educate them to prevent infection, and vaccines. Regarding because spleen is slowly dying, they're more prone for infections from the capsulated organisms like pneumococcal, meningococcal. So these vaccines has to be given, but still the country has not come out with any regulations, guidelines. It's happening, but it yet to come out, because we usually pneumococcal vaccine in the routine immunization schedule, what is given for small children, it is only PCV10. But these people require PCV 13 and 23 variants, strain variants, which is not yet being done everywhere. Only in private setup or some setup where active sickle cell work is going on, they are doing this. Then Haemophilus influenza, and they're prone for typhoid. Typhoid worsens their crisis, so this is also given. They have to undergo, it's like every annual checkup. Like IT people undergo routine annual checkup, they have to regularly undergo checkup to identify the early markers or early indicators of any organ damage. And education regarding their preventive measure like extreme, as I mentioned earlier, and also to avoid smoking and alcohol. Now what is the happening? That is, anybody, any child whether symptomatic or not, more than 2 years, is given a magic drug they call hydroxyurea. Hydroxyurea, the basis they thought was it's an anti-cancer drug. This is given 10 to 15 mg per kg to all the people who are diagnosed as sickle cell, irrespective of symptom. Earlier, they thought at least 2 crisis episode, but now irrespective of symptoms, they are giving. So initial stages, we had a difficult, oh, you're giving a cancer drug. What if some damage happens to us? So many of the places, the hydroxyurea hardly has shown any adverse reactions. The basis for this drug is it is supposed to increase the HbF level and expression, but F cells are increased, but the in Indian context, we don't know. There are many more mechanisms beyond increasing the HbF level, which it is really functioning. But after giving hydroxyurea, we have seen a lot of improvement in the quality of life of the people. We need more evidence now. We are coming up with evidence on the role of hydroxyurea in person with sickle cell disease. If a child is less than 2 years, about 2 years, even a medical officer, anybody with MBBS can prescribe this first time. So if it is less than 2 years, it requires a pediatrician to, and from 9 they don't prescribe. So 2 to 9 months, if the child is symptomatic, they are given till we have new drugs. Many clinical trials are ongoing now. Till then, it is lifelong prescription. Hydroxyurea has to be given. So this is mandatory drug along with the folic acid. Every day they have to take. The initial challenges we faced was this tablet comes as a capsule. Capsule is 500 mg. You could imagine a capsule. If I am a child who is 10 kg, I need 10 mg per kg means 100 mg. The capsule is 500 mg. Before the government was giving this free of cost, I have to open the capsule, take the powder, divide it into 5 portions, which will be just a pinch. So this was biggest challenge. And also when I paid, it used to be 15 rupees to 20 rupees per tablet of hydroxyurea. Lifelong means, imagine, villagers used to really find low socioeconomic status, tribal people used to cry how much we need to spend for this particular tablet. But of late, we have got the formulation. 100 ml syrup has come, but not it into the national program, but it is available in a syrup mode that would in future would solve us the challenge of this dosing related to hydroxyurea. So this along with folic acid is regularly taken. Less than 5 years, because they are prone for infection from 90th day of life, up to 5 years. So the child has to daily take penicillin. This is as per the guidelines. But biggest challenge is that the penicillin injection. Imagine if you up to 5 years, every day you have to go and take an injection. No, that's very challenging. And in the government, getting oral penicillin V it's hardly supplied. So though it is very well written, the dosing, even IAP gives this dosings, but availability of this for daily consumption is very much difficult because of non-supply of the oral penicillin V. But current practice is people are prescribing in case of infection. But if the hematologist has been visited, the children are regularly taking the antibiotics, that is any amox group of drugs or erythromycin is given to them. So I said 10 mg to 15 mg per kg, they can increase even up to 30 mg per kg without any side effects. Slowly they escalate. Hydroxyurea alone can be spoken for hours together. Usually what we do is we ask them to take it night, because if they sleep, all minor side effects like nausea, vomiting will be just forgotten, or they won't get to know because they are already sleeping. So in children, what we do, this is a till last few years, we have been in field struggling to divide this 500 mg hydroxyurea. We put it in 10 ml of a bottle, then make it into a liquid, give them the dosing chart. This is what we have been trying at the tribal level. So, but what is that? To ensure that we are safe while giving an anti-cancer drug, baseline CBC is done, baseline LFT, RFT we are done, and if it is an adult female, then we ensure that, because it is contraindicated to take this. Though in many of the hematologists and even in Gujarat, a group of researchers have given during pregnancy and they have found it to be safe. So still, as per the guidelines, if a lady is pregnant, from the day she found out, this has to be stopped, outweigh with the symptom and then prescribe under hematologist guidance, or and also up to first 6 months of breastfeeding, the hydroxyurea should not be given. This is very, very important to be practiced. So LFT, RFT is done. And this is because if a person has a side effect, it will happen within few days or even a month of taking hydroxyurea. They will go for a pancytopenia. So guidelines are there how to go with that also. But I would just end here saying that if pancytopenia is observed, it has to, this is a one thing which we should carefully monitor once the hydroxyurea is initiated. So as I mentioned, headache, nausea, vomiting. So that can be averted by giving a nighttime dosage. Symptoms will subside with time. So pain is the one which commonly, which we observe, that usually we educate them, keep paracetamol at home. If it is so difficult, we add an aceclofenac or a diclofenac. These all can be managed at home only. We educate them in 0 to 10 how to assess their pain status. If it is mild, manage at home. Moderate, go to nearest hospital. Take a daycare support, and if it is very severe, then get an admitted. So stroke, chest pain, severe abdominal pain, they are all indicators for admission and immediate call for ambulance, because it requires a dilution by giving IV fluids, or even blood transfusion is required, because many of the doctors at peripheral level, they fear to give tramadol injection. So under the care of a good setup, like at least a taluk hospital, tramadol can be given. Even with the morphine is also given as an injection. So initial first month, third month, 6th month, and then annual checkup is also sufficient. These are the list, like we do RFT, LFT, oxygen saturation, we do on a camp mode. Even transcranial Doppler is one good thing which will help us to based on the cerebral blood flow, impending stroke can be evaluated. Echo is also done routinely on an annual basis. Then ferritin level, suppose there is excessive hemolysis, they are going for hemolytic picture, then ferritin accordingly, iron overload has to be treated. Eye screening, MRI, and especially with angiography. And the one most ignored part is their psychological status. We have seen many of them going for impending fear of pain. I had one person, every time during the exam, one child, is it really a crisis or his psychological status? We couldn't differentiate. We had to do all varieties of tests. Everything used to come normal, but he used to have severe pain episode, which he used to explain. But whether was it really there or is it's a psychosomatic, we finally it ended up with a psychological clinical psychologist who helped him with to come out of this fear of impending crisis. So danger signs I have already mentioned. They have to require an immediate referral. And one important thing is that now government has declared this as a disability. They can, because invisible, initially doctors, when they used to go, they used to say, you are fine. You don't have any visible disability. Why should I give you a disability card? But now the amendment has been done. The Gazette is clearly explaining that they are entitled to avail 40% disability if you have a HPLC and above reports. The score given is 40% for SS and beta thal. Other variety 30% is given. So 40%, as I mentioned, it can be renewed once in 5 years. Individual state specific, like Andhra is giving 10,000. They're very rich state, so they give 10,000 per patient, but Karnataka, they get 800 rupees, and even elsewhere. and they get 50% discount in their railway and the road transport. So if they undergo BMT, they are not eligible. But BMT is also usually not recommended like thalassemia. There are a lot of criteria, so many crises, so many episodes of chest syndrome or splenic crisis is a basic mandate to take them for the BMT. And they have also relaxed the people who can sign. Even at a taluk hospital, the medical officer with another 2 people as a team who are assigned by the government can give this, issue this certificate. They need not come to a district hospital. So this is a gazette where they have modified the regulation for hemophilia. It's freely available. March 2024, this was revised and it is freely available. Hemophilia, thalassemia, and sickle cell disorders. I wish like similarly we have entry of many more genetic disorders who can bring this, who can get these benefits. So the registry, though it has been meticulously designed, it is very much underutilized, because how much, if I go to a peripheral healthcare worker, that is a medical officer, they say I have 22 programs. How many more programs are you going to push me? And there is no public private partnership which has been yet in the national program. I think we need to really think in so many directions. How can we really make this program efficient and detect more people and also utilize the preventive measures? So one important point, we speak so much of the principles of genetic counseling. So we are doing benefit. But in a national program, are we maintaining confidentiality? No. They're openly announcing. The paper gave, the minister came, 40 people diagnosed with this. They gave a card and they took a beautiful pictures. It was put in papers. So we follow so much of confidentiality concerns during genetic counseling. But where is it? Autonomy. They are not given a decision. Should I get screened or not? So informed decisions. So these are, is there a fair play, which is all these principles which we speak big during genetic testing is not really being. How many components we need to relax as a national program, how many components we should really respect is not being yet considered. Probably this is where the representation of genetic counselor in this national board during the designing of this program was missing, would have been the major concern or a major pressing need which should have been considered earlier. So what is the problem of this as the why I would say the mission is in crisis? Because they've taken a first genetic disease as a national program and explaining the world that you're a carrier is such a challenge. I'm normal. Why are you coming me and telling that I have something? This is the biggest problem. You are not educated. You are not understanding, because sometimes when the health worker comes, they run away, because if you test me as positive, my child is not going to get married. The girl in my family is not, because marriage is a priority in India. Psychological and implication is stigma is so much that people are really getting stressed because of the national program. And eradication, first step is addressing the one side. Then we have to also add efficient management and the other measures to reduce the disease burden. Many of them are not yet being considered. So none of the counseling, whether it is premarital, preconception, these are all not in place. There is many of, like Karnataka doesn't have yet fetal medicine expert attached to the government hospital. Now private, they're not funded. I have to take all of them to Bangalore. And if one of the tribal lady, we were to explain them, entire family took them halfway through, they almost ran away. But in some places in Maharashtra, it's running very, CVS is being done very efficiently. And this is happening in connection with the labs elsewhere. They are connected across states. From Maharashtra, it is sent to Andhra and it is getting done. So maybe we have to work it out how we can all together make this possible. So we need to go a long way with premarital, prenatal, postnatal, all these has to be taken further. Before that, education and also considering their income, how should we go? Access to healthcare and social stigma has to be really addressed. It's not just one mutation. So what is required is both one-to-one group and psychological counseling is required. So education, no, not to treat this as the message what I would like to say is not to treat it like any routine program. Please keep in mind the stigma and give the social support. So every level, whether it is healthcare system or community, we need to go a lot. So center of excellence in every district is being formed now. If you are in a specific state, find out which is your nearest. For Karnataka, it is Mysore, like that. A center of now the center of excellence has been renamed as center of competence, that is COCs exclusively. It is not the center of excellence like for rare diseases. It is different. It has been funded by Ministry of Tribal Affairs. So as I said, the hiccups are resources are less, registry is still in an initial baby stage, trainings are not happening, referral mechanism has not yet developed. So this is what is the current status. We have, I think any of you as a researchers are interested, please do participate in large scale studies for evidence on this, cost benefit analysis, and also any more drug curative therapies make in India. We need gene therapy. Gene therapy, we speak big in newspapers. And when somebody reads a newspaper, they call and ask, can I get it tomorrow itself? So they wouldn't know the implication, how much it takes, how the files still remain in the desk of bureaucrats at different level for permissions and many of the requirements. So these are the challenges which we really need to think of, and also the evidence on all these are required. So with this, these are some of the efforts nationally it is going on. We are working as a task force in different states, different group of researchers at various levels, whether it is ICMR, that is NIIH, or headquarters, or even different centers are working on sickle cell disease. So these are the education events at field which is being conducted. So many methods, like if you give pamphlet to them, it will become a paper to eat something. This was what was observed in field. So they were educated through the local methods, traditional methods, to make them understand. You can see that we utilize the government, the DC is addressing here about the disease. If it comes from a higher level ups, they themselves take a responsibility, it will work better. Some of the steps we have developed, it's anybody interested, you can send your mail ID. This is a program developed. These all are, you can see the stalwarts, the Dr. Tulika Seth or Deepti Jain. All these people were the one who designed this program. They have developed a module on basics. All these what I spoke in 15 modules is available as a certificate course from JSS. So that is called Ambari Sickle Cell certification on SCD. Anybody interested would directly please message me. We will help you to get it free of cost. Then we have as a welcome trust funding, we have developed a registry to see how a dynamic registry is really needed. So that is called as Samhita. This is how our interface is working from screening till finally we would like to develop an ideal model of registry. A pilot is ongoing, will be completed next year. Anybody interested could share the results too. So this is how we have our dashboard, which clearly gives a real time. If a person goes to hospital, there only the concerned doctor will enter the reasons for visit, follow up, everything is there from starting from enrollment till the follow up. So we have not only done ourselves as researchers or a genetic counselor, we have involved the MOTA, we have involved NASCO, that is National Alliance. It's the patient advocacy group for sickle cell. We have involved Tribal Welfare Department, Ministry of Family Welfare. These are from different states. And we have done ASHA training, staff nurse training, and the hematologists trained all the medical officers across India on management. So different programs where these are initial steps which are happening, but it should really have a robust mechanism to for a continued practice. It's not just a one-time exercise. You can see that education event we have tried from posters till you can see the traditional healers, wall paintings were used, folk dance have been used. We have used school sensitization, mobile clinics, auto announcement. What I want to say is that it's not just one method which works. We couldn't use any reels or anything here because these are the people with button phones or no phones. Still worse, no signal at all. So we use different methods at the local level. You can see in the marketplaces we have tried, in tea gardens we have tried, schools we have tried, in the places where they commonly come and take their daily routine groceries, we have tried to educate them. So folk dance you can see, which indicates we have even used the puppet shows to educate the students on the symptoms of sickle cell disease has been done. This is pan India try through the task force which we have done. So you can see the paintings on some common symptoms. You can see that the traditional healing practices are enrooted. So we didn't want to hurt their sentiments. So we got them and we educated them to take up the awareness programs. So medical officer training. We still need a telemedicine practice which has to develop, but we have tried to connect it with e-Sanjeevani so that the peripheral people, similar like COVID they use, this has been tried. So different screening methods, so involvement of politicians. So these are some of the baby steps which are happening. I won't say that many of the stalwarts are there across India. They're working in groups. Many of sickle cell institutes are there. Gujarat has a very good model. Even in Chhattisgarh, there is a good model. Sangwari, JSS, many are there. PK Patra sirs. So many are there. It's only need is that we all should come together and work for the disease rather than for our own group. So it's just few percentage of the sickle cell information I have given in this session, because I thought we are all dealing with big diseases during the genetic counseling process, but we never think of the sickle cell disease. We ought to know what is happening in a national level. So I thought this would be a good platform to disseminate about the ongoing mission, so that if you can even think for screening anybody for a sickle cell disease in future. So with this, I would like to end my session on how our hemoglobin causes crisis, but at present stage is going with the recovery phase, as well as it's happening, but still we should ensure in future that this is totally under asymptomatic period, or even gene therapy, which would take us towards the elimination of the disease. Thank you. So if anybody has any queries, I would like to take it up.
Thank you, Dr. Deepa. It was amazing. I can't say because I'm speechless now. I have a lot of questions to put on and throw in front of you prior to this presentation. But now I'm completely speechless because it was, in fact, an eye-opener to me. So fascinating because we understand how much challenges are, and especially as you mentioned, the division of the capsule of drug into 5 parts. That itself make to say that how much compassionate you people are doing this, and this is such a brilliant thing. And in fact, I have a lot of questions and things like putting the regional demographic pictures or illustrations in their regional languages at their villages and all. But you people doing nothing sort of an extraordinary job at every corner, even with puppets and even with the auto boards and everything whatnot. And this is incredible, and I hope this will definitely bring some sort of change among all the people and the things. And this was so impressive. And yeah, I personally, to me, I thought a lot of policy making things are quite that is peripherally, while in communication, while in thoughts was completely different, but while going to the on field and making to the people, that will bring a lot of difference. It's an incredible book, incredible book. I'm really speechless. And yeah, fortunately, we hope for a better thing. And yeah, I think we have a couple of questions.
Yes, Dr. Sai. So I think the first one, what about gene therapy? Yes, gene
Yeah.
therapy is already, it's a very simple. We know that it's 1 point mutation, but it's available elsewhere. It has been done initially. The viral vectors were tried and that had its own complications. But now even the CRISPR-Cas technology has revolutionized this. But we need how Indian studies, it was actually brought, the AIMS Delhi was made as a center, a very huge amount was poured there, but what is the status of it is lying in a desk of a bureaucrat. This is what is a current update we know. Recruitments should happen, that should generate evidence on the safety measures and as per the regulations of gene therapy. Only then, but till then definitely I would say we are going too far with gene therapy. If I can diagnose it at a very early stage, start a simple medication. I have an 81-year-old lady who was taking all herbal medicines in her own setup, who had never had any symptoms. So it's a very diverse manifestation phenotype we have observed. Some kids are there who regularly go to hospital, and we have found that certain particular age, 5 to 8, there is a surge in their manifestation, then again at puberty, then again at pregnancy. So during this period, if we take care, in between period there are really symptom free. This changes in their symptom is observed across ages. Still, till all this gene therapy comes to India in on a routine cost efficient method, we can still work on identifying who has it, and also giving this basic medication which almost 60 to 70% lead a very good life. So that itself would be a biggest achievement when it becomes such a huge 1,80,000 people, is something which we can do the routine management itself.
Got it. And I have a couple of questions, Deepa.
Yes.
See, as you mentioned, there are a lot of cases where we are indicated, like there are positive cases are there, and the couple of cases are screened to be carriers. So my question is, so as usual, it's a community level based epidemic regions. As you mentioned, there are a lot of regions where there are a lot of sickle cell cases are more profoundly found. So soon after we found there are a lot of positive cases, and what are we build a sustainable support system, because the people will get anemic and they need regular blood transfusions. So what are the sustainable support system for children and families already living with sickle cell disease?
Yeah, now the at peripheral, I said Ayushman Arogya Mandir, that is a sub-center level only, health and wellness center only. Hydroxyurea is now available from the government. So they just have to, and also they are going to incentivize ASHA workers. So if you take care of one sickle cell, you will be given money. This is how, like, the success of tuberculosis program they are utilizing to bring it up into the sickle cell system. They ensure that they are taking regular hydroxyureas. All these are maintained, and still government is learning how to do, but some states it is supported by NGOs, are already years of sickle cell work. Researchers, foundations are assisting them, because I see in almost Ambikapur district of Chhattisgarh, there the Sangwari and JSS have really made a PHC system very robust. Per day, they have assigned 1 day as a sickle cell clinic at a government hospital. So now people are aware and they come. And during sickle cell day, instead of calling speakers, we learning ourselves, they are calling the sickle patient, so that they lose that inhibition and that stigma is gone. They come and they speak their lived experiences. So different models are there. We are evolving, which is a good way of bringing or improving the mission. Anything which we begin initially will have all these challenges. It will over the years get fine-tuned and improved. Definitely the efforts of government is very good. The free medications are there, free treatment is there, but only thing is awareness is less. So now it is our, and one more biggest thing is we have requested at different level, let the counselors be there. Let the government themselves appoint the counselor, so that it also will generate a job requirement, and also will address many other concerns. So slowly we can add sickle with thal and many more genetic disorders. So this has to raise as a unison from a national level. So it's a long way to go, but it's definitely happened.
Absolutely. In the same way, we've got to know that a lot of people are carriers. And what about their follow-up and their soon after, how many people are getting married and what are there about their prenatal testings and how can we get to know?
One thing is the few things. So what is happening is they go to the field, they get tested. The biggest challenge which is happening is they are not told what is their report. And the funniest part is many people are at many places, different organizations are repeating the test, but due to national program, this repetitions have been averted now. So the screening of carriers is happening, follow. There are rules. If you open that national guidelines book, very clear guidelines are given. But in some state like Karnataka, we like from private, we have been backing up the government. So we are doing now once in 3 month health camp mode only. We are generating funds. We are doing in a government hospital only. At one stop, we will disseminate information. All the patients will come, get all these tests done. They are categorized into based on their severity. So this mechanism should happen at all the states. This is it's in place now. And prenatal diagnosis is, they're really not so understanding the importance, especially in our tribal area of Karnataka. If I explain prenatal diagnosis, they don't. They're not coming up for taking it. It's okay. One child is living with medicine. Let the other child also be. So they're not getting to know the importance. This we need more work on, or awareness also. The biggest challenge, one more we face, is if during antenatal testing a pregnant lady is found to be carrier, we call the spouse never comes, he just runs away. 2 months, 3 months, we have to really go behind them to get tested. So tell what is the possibility or preparedness for the birth of an affected child if not prenatal. So these challenges we are facing, so this has to be worked in long way.
Definitely understood. See, yeah, as you mentioned, it's included with a lot of psychosocial aspects too. As you mentioned, soon after they are confirming as carriers, then the marital activities are quite different and difficult to approach.
And the
But
blame on the female is also one more concern, like you are
yeah,
responsible. This is also has been observed at many places.
yeah,
And many of them are even thinking it's a curse of the god. We moved out of the forest, we ate like some form of non-veg, the forest goddess. So these are the very much beliefs which we have gathered. So they think that it is because of so many of the even black magic. This has been told by many of the patients. That's why we are affected.
yes. It depends on their belief system and
Yeah, the
lack of
local
awareness.
belief system.
Okay. Yeah, that's absolute today. It was a so fantastic thing. And I hope some more questions are there. Mm. Yeah, some people are interested to
Yeah,
join.
once you dissolve, what we do is one capsule we have tried up to not more than a week. They say the effectiveness of it reduces. Second thing is how much hygiene. It's not that it's the best way, but it was the only way available for us, so we dissolved. But usually up to 3 days we have found it is efficient, but we don't have any evidence on what is the real the efficiency of that tablet on third day. But this is the only way in children we could use it.
Right.
Yeah, Dr. Archana, we will share I'll take your email ID, and we will mail you from the university for the course. You can take it up, and we will put it across the forums also.
Right. So yeah, the finally, what would your one strong message to your the young doctors and public health leaders working on rare diseases and blood disorders?
So number one is that don't ignore sickle cell disease. If any place you come across, inform the nearest district system or you diagnose and give the as much as information as possible. And not only sickle, all hemoglobinopathies in total.
Right. It's absolutely fantastic and phenomenal to know all the things. So we're looking forward, and we're very much enthusiastic to join hands with your team and all. So I think one more question from Archana Kher. Course is online. I'm able to join.
Yeah, it's online. It's online.
Right.
Anybody can do across the world. It's online, self-paced. Few questions are there. So finally, but currently the certificate is provided by Karnataka government NHM and the JSS Vice Chancellor. But in future, we are planning to extend it through NHSRC to all the states so that individual state specific certificate is given. But currently it is given by the NHM, the blood cell of Karnataka.
Great. Thank you, ma'am. Thank you so much. Your dedication to bridging clinical care with public health is truly inspiring. We are incredibly grateful to have had your expertise guidance today's session. Thank you so much. We'll have much more sessions from you. Thank you. Thank you, ma'am.
Thank you. Thank you. Thank you, ORDI, and thank you, Dr. Krishnasai.
Thank you, ma'am. Yeah.
Thank you so much, Deepa ma'am, and thank you so much, Dr. Krishnasai.
Thank you.
Thank you.